I'm just making sure. It always takes a few seconds, so when you actually do the editing, it doesn't come on straight away. I'm just waiting a minute. Okay. It's all on. Make sure I'm in frame, and then I can go into exactly what I'm going to discuss today, which is all about reversing type 2 diabetes. So the reason I brought this one up was, well, the first reason was I actually put it out as a poll on the YouTube community, and that's the one that got the most votes, albeit there wasn't many votes, but at least it got something. So that is what I'm going to be talking about today. So for anyone who is interested, it will be reversing or putting it into remission. So it's type 2 diabetes mellitus. So that is what we are doing today. So there's a few things, if you did watch the live earlier on this week, a lot of these things are going to be overlapping in terms of principles. However, there's a few things that I need to bring up and go through the physiology and then come up with practical ways that you can reverse or put type 2 diabetes into remission. By all means, put your questions as we go along into the chat box and I will come through to them probably closer to the end, and then I can go through and do a Q&A session. So the first thing is, what is type 2 diabetes? So a lot of people say, I've got diabetes, but there are two main types. Yes, there are more differentiations of it. I am one of them people. I have got a rare genetic type. However, the two main ones are type 1 and type 2. The main difference between them, type 1 is an autoimmune condition. So that means that your body is essentially eating itself and it attacks the pancreas where we make insulin. And type 2 is usually due to insulin insensitivity, and it is something where it is usually developed through lifestyle. Yes, we do have genetic things in certain, or it makes us more predisposed to having type 2 diabetes. However, it is mainly due to lifestyle. So a few stats before we go on, and then a few things that we need to debunk. So type 2 diabetes, why is it so prevalent at the moment? So back in I want to say it was 1985, there was about 30 million people who had it, which is now, in the current day and age, is about 840 million. So you can see that type 2 diabetes is growing with the way that we are living. And the reason being is that type 2 diabetes is a condition, pardon me, I've still got a cold, is a condition or a disease of abundance. And that is because the body is unable to use energy effectively, so it puts fat in the wrong places. That's essentially what it is. But for those who are watching it who may not have type 2 diabetes, they may either have a family history of type 2 diabetes, they may be classed as pre-diabetic, or they actually do have type 2 diabetes. Then what is the reason as to why you would like to go into remission or try and reverse it? And the main reasons are, like I've said previously, it can affect your eyes, it can affect your kidneys. I don't know why I'm writing these out at the same time. It can increase your cardiovascular risk, meaning heart attacks and strokes, and it can cause nerve damage. So there are many other things that diabetes can cause. Also, it can reduce your lifespan, even in the modern era, up to 10 years' time, which is still a crazy statistic, given the fact that we are so advanced with the medical management that we've got. So if anyone's wondering why I'm looking over here, that is where I will see the questions later on. But let's go into why type 2 diabetes comes about, and then once you understand why type 2 diabetes manifests, then you can go about preventing it or putting it into remission. So the first thing is that it all involves insulin. So insulin is a hormone which a lot of people try and reduce these days, but basically insulin leads to growth. And that is the biggest thing. So when you think of insulin, you should think of growth. And when I mean growth, it should be a way of conserving energy. So in the terms of amino acids or protein in your diet, it wants to make it into actual protein. So it wants to put it into muscle. When it comes to carbohydrates, it wants to put them into the muscle as glycogen. And when it comes to fat, it either just basically wants to store it as fat. So that is what insulin is doing. It is showing that your body is in a fed state and that we have energy available, so let's put it away. But as with all things, there needs to be a fine balance, and insulin is one of the things where if it is unbalanced, it can then lead to a lot of disorders. Now, insulin resistance is the main causal or risk factor when it comes to type 2 diabetes. And depending on the questions later on in this, depending on what level you want me to go into, I can go into it in more detail. However, it will eventually end up with the liver not listening to, I'm going to draw a box for the liver. It will eventually end up as the liver not listening to insulin. And even though the body has enough energy, it will still want to make more sugar. And it will also want to put out more fat. And this is the issue because sugar will also go to fat. And that fat will eventually go into the pancreas, as long as many other places in the body. And then that is when we get a reduction in insulin from the pancreas, because that's where it's made. And that is where type 2 diabetes becomes a vicious cycle, because they all feed into each other. And the reason why this is the supported theory was that, and this will lead on to how we can treat or prevent type 2 diabetes. It was brought up in 2008. There were a couple of professors. One of them was called Roy Taylor, I think. Don't remember off the top of my head. However, they come up with something called, you can all fact check this as much as you want, the twin cycle theory. Now, basically, this is one thing in which a lot of health professionals and a lot of the public don't seem to grasp. And when they think of diabetes, they think of a disease of sugar, because that was originally where the terms come from. Diabetes is the Greek term to siphon, and mellitus is the Latin word for sweet or honey. So it was to basically pass sweet urine. So that is why everyone thinks diabetes is a disease of sugar, which it is, but largely it's due to the fact that we are storing fat in the wrong places. And when we store fat in the wrong places, such as the liver and pancreas, we can lead to a reduction in insulin production, a reduction in insulin sensitivity. And then that is why this theory come about, because the study originally started off with, I think it was only 11 people. It was only a short study, but they put people onto a 800 calorie, I hope you can actually see this, 800 calorie per day diet. And for the 11 people, basically, they ensured that all of them lost weight. And those who lost weight ended up having a better insulin production, greater insulin sensitivity, and then that reduced their diabetes and put them into remission. This was then further supported by another study by the same people called the Direct trial. And it was on more people. It was about 298, 300 people. And it then further solidified the fact that if you reduce weight, you have a lower fat storage within certain organs in the body, you will get a better response towards glucose management and a reduction in diabetes. And it was all graded on how much weight you lost. So the biggest thing when it comes to reversing type 2 diabetes is reducing the amount of fat mass that you have. So in terms of how you go about that, there are many ways. So obviously when it comes to diet, there are a few fundamental things. If you've got too much fat, then you just reduce the amount of energy that you are eating. So obviously we normally measure that within calories. So some people like to, and I don't want to go into this because I don't fully believe the calorie style of dieting, because there's so many variables that can change. However, for simplicity, if you are highly obese and you've got a lot of fat, there's a good chance that you could benefit from calorie tracking. So if you are currently eating about 5,000 calories a day, by slashing that in half, it's still manageable. You will reduce a lot of fat and you will improve insulin sensitivity, along with a lot of other things along with it. So with your diet, decrease the amount of energy that you are eating. Make sure you are tracking what you are eating. So that is a big thing, because when we look into human studies with regards to diet and lifestyle, humans are inherently biased at underestimating what they are eating. So when we do these food diaries, they normally come up with abnormal results sometimes, because we just go, if I asked you now, what did you eat early on this morning? Even me, to the gram and to the actual quantity, I probably wouldn't be able to tell you what I've ate this morning and what I've had this afternoon. And that is where you create bias, because after 24 hours and you're trying to recall it, that is when it becomes an issue. So I'm actually going to put this here because I think the whiteboard is slowly dipping below. I'm just going to double check this. Right, so that is the first thing. Diet, reduce your energy. There are other things that we can do with this. Obviously, reduce the amount of ultra processed foods, have no more than 20% of your diet. All the same things apply in terms of high protein, all them things. Now, the next thing obviously is exercise. Now, I'm going to do its own section on exercise because with diabetes, I've said this so many times if you've watched any of my stuff. So we'll put exercise as the top. Now, muscle mass is your friend when it comes to diabetes management. And one thing that I don't like is that when I see a patient come into the surgery and they've had a review with another professional, and it will normally follow something like this: blood sugar control is okay, could be improved. Patients will reduce the amount of fats, such as butter, and reduce the amount of cheese that they are eating. They are aware that they need to improve their exercise. Will review in 3 to 6 months. That is basically the majority of diabetic reviews held within the UK. And I understand this is not me shaming health professionals, because when you actually look at the patient lists and the numbers and the amount of people that are having this condition, as we've just seen, it is multiplied into the 800 plus million globally. In the UK, I think that number is about, for type 2 diabetes, around 5 million, 5.2 million. There's so many people who are undiagnosed as well. So when you're actually factoring that in with the health service that we've got, you need to try and get the most efficient process in there. However, there are things that could be passed on to patients, which I try and do when I do a consultation. So when it's advising patients to improve their exercise, it falls into two camps. One of them is to improve muscle mass, and this usually comes about by resistance training. Now, why do we want to improve muscle mass? Basically, the muscle cell is one of the only cells in the body, there are a few others, but one of the only cells in the body that can have sugar, which I'm going to put here. Sugar can go into the muscle cell without the need for insulin. Now, if you remember what I've said earlier on within this live stream, when you are type 2 diabetic, there's a good chance that your body is not responding to any form of insulin, or if it is limited. So the idea that sugar can come into a cell without the need for insulin is a bonus. And the way that it does that is when you are contracting your muscles, it puts these little transporters to the membrane and allows sugar to go in that way without the need for insulin. So if you've got more muscle, you've got more active muscle, you will have greater utilization of sugar. And then when it is in the muscle cell, if it's not being used for energy within the mitochondria, it can be stored as glycogen. And if you've got more muscle, it means we can store more of it. So it is reducing the amount of sugar within your blood. Reducing the sugar in your blood is good for a few reasons, because sugar itself can be toxic in high amounts. It can cause damage to blood vessels and nerves, and that is why a lot of diabetic patients have issues when it comes to wound healing. And the other thing with sugar, like I said on the previous live stream, is that if you have too much sugar and there is no need for it in terms of glycogen or energy, we will put it into fat. And depending on how your body stores fat, which I will come on to later on, can be even worse for your health going forward. So if you increase muscle mass through resistance training, that is why it is so beneficial in diabetes. But for a lot of people, like I've just said, we say improve your exercise, improve your diet, blah, blah, blah. Go on and do your own thing. And lo and behold, a lot of these things actually do not come to fruition. I can see there's a lot of questions and I will come back to them, believe me. So with resistance training, how do I go about it for a lot of people? And the best way is to assess where your baseline is. So if you are not exercising whatsoever in the gym, my aim would be to start going at least once a week. Do these things in a sense where it's manageable. And if you keep it consistent, it then helps you psychologically because you are adhering to something. So you get a greater return. There's an emotional boost with that as well. But if you are able to commit 2 to 3 times a week, I would be looking to do the major muscle groups. So do an upper body, do a lower body, and then you can even do a full body. So once you now know the fact that you need to try and exercise as much muscles at once, because that is what's going to increase the amount of energy demand, it's also going to increase the amount of muscle that you can build. Then how do you then tailor your exercises towards building muscle? So you may have heard of reps, you may have heard of sets, So a rep is a repetition in terms of if you do a bicep curl, that's the example I always use. If you do one bicep curl, that is one rep. I would normally aim for a lot of people 6 to 10 because it allows you to build a bit of strength but doesn't overdo it in terms of making the weight too light that you can do too many. When it comes to sets, this is how many times you perform the amount of repetitions here. So if I do 8 reps in one go and I do it 3 more times, that's 3 sets of 8. I would normally go on average for an exercise around 3 working sets. And working sets is the sense of if you pick a weight, that can be body weight as well, where you feel as though that is your ceiling and you can't do any more, then you should do 3 working sets at that volume, at that weight. And if you do that for a few exercises and all do it dependent upon how you perceive it, the activity to be. So that is something called rate of perceived exertion. There are obviously more qualified people on YouTube to go through exercise plans, but I just wanted to give a bit more clarity as to how to improve muscle mass and do resistance training. And this is subjective. So a 10 for you might be an 11 for me. It could be a 4 for me. It's all dependent on what your physical fitness is at that moment in time and what you're capable of doing. And I would normally aim for an exertion of about 8 to 9 because then that shows you're giving enough, you're pushing your body to the limits, which is going to promote new muscle growth. So that's what I mean with resistance training and muscle mass. That is why it's so beneficial. The other one, when it comes to exercise, is something I always mention, zone 2 training. That is basically using the amount of fats in your body as fuel as opposed to putting it as storage. And like I keep saying, I will come on to the reasons as to why fat being stored in the wrong places is obviously not the best for your health. So zone 2, minimum amount should be at least, obviously, doing something over nothing is the best. 60 minutes a week is where you're going to get a good return. Ideally, you want it to be about 150 minutes. How do you do zone 2? Go back on many of my other videos. I will go through it so many times, but it's where you can still hold a conversation, but just about when you are doing an activity such as running, walking, cycling, rowing, whatever it is that you are best suited to and you can do on a reproducible level. That is why it's going to be so beneficial because it uses fat. So with the fact of using sugar here, increasing the amount of utilization of energy and reducing the fat, you are going to have a greater outcome when it comes to type 2 diabetes. And when you bear this in mind, so they're the 2 main things we're going to go through is diet and exercise. I'll go on to a few things now and then obviously go through a few questions. But the studies that were done, like I said, you can look at them. There's one called the direct study. It was all based on the twin cycle theory. And all they done or did was they reduced someone's calories to 800 to 900 per day, give or take. And they'd done that for a period of 8 to 12 weeks. Then they achieved this, by the way, so there are a lot of improvements. So this is what I'm going to go through is the barrier for putting the type 2 diabetes into remission, which basically means the condition is no longer present. Then the barrier is so low for it that if you do something that's above and beyond, like I've gone through here, then you're going to have a greater return. So they done this using processed, they actually didn't use the word processed, but processed shakes. And then after this period of time, they then went to solid food, introducing it, and then they went to a normal diet, and I'm putting normal in inverted commas because it was still restricted to some degree. Now, the thing I want to draw your attention to is that when I say about muscle mass and improving all them things, that is going to give you a greater return on a lot of things because in these people, the average rate of remission. So when I mean remission, if you've got type 2 diabetes, it is classed as you having a HbA1c, which I'll put here so you can see, HbA1c. That is the blood marker we use to diagnose type 2 diabetes in the large majority of cases. In the UK, we use millimoles per mole. Once you have a value greater than 48 millimoles per mole, you have type 2 diabetes by definition on a couple of times. That needs to be tested at least twice. Remission is also the inverse of that. So if you have a level below this on 2 occasions, normally about 3 months apart, you are classed as no longer having type 2 diabetes and the disease or the condition is in remission. So in this study, when you lost more weight, so as the weight increased up to about 15 kilos weight loss or more, from 0 kilos, you had a greater rate of remission, so a greater chance that you would not have type 2 diabetes. And the percent here, so after about 1 year, 86% of people who lost 15 kilos or more were still classed as not having type 2 diabetes, which just based on the fact that they were only having a calorie reduction using ultra processed food and there wasn't really any strict routines with regards to exercise, this figure could near enough be closer to 100 in my opinion, and you could probably get it with having a lower weight loss. So that shows you the scope. I think at 10 kilos weight loss it was about 57%. Again, I don't remember the numbers off the top of my head lower down, but you can see the picture is the more weight loss that you have, it will lead to a greater chance that you are having remission of type 2 diabetes. Now, it's all well and good trying to reduce these things, and you will get obviously the odd patient or the odd person who will say, I've tried to do these things, however, I have not had any success. Once you've then confirmed, which is going to be very rare, if you follow all the things I've just said, then there's a good chance you will be in some of the best shape that you've ever been, and that's physically and metabolically. However, it all depends on when your diagnosis of type 2 diabetes was or pre-diabetes as well. So a lot of these studies are saying if you have had a type 2 diabetes diagnosis in the last 6 years, you have the best chance of reversal. Obviously, that chance increases the closer you get towards 0 years in terms of intervention. You can still reverse it or put it into remission when you get to 10 years and more. However, by this point, your body has obviously had a lot of adaptation to make, and it makes it just a bit more complicated when it comes to having normal physiological function after 10 years of metabolic dysfunction and damage. So that was the point I wanted to make there. I brought up, before I go into a few questions and then go over a few of the other topics that might come up, was I keep talking about this fact that fat and about the fact that type 2 diabetes is normally a disease in people who are obese or overweight, which is largely true. And that is because when you think of an obese person, and again, I'm going to do a disclaimer at the end, I put one in here, it's not medical advice, and this is not meant to offend anyone, but for illustration purposes, if you have someone who is obese, has a lot of central mass, as you can see here, this person metabolically could be actually okay with regards to someone who is like this but has a fat disorder. And that is why I always like to make people aware of the fact that this person can have type 2 diabetes, but you can still get type 2 diabetes and having a normal BMI. And a lot of the people within the studies that I've just went through had a BMI of greater than 27, 28. So they are classed as overweight going into the obese category. And some of them had in the 40s. But there was a study showing that those people who have a normal BMI, and for white people, that is anything from about 18.5 to 24.9. Well, got to remember my stuff now. And if you are basically of any other ethnic background, which is insane because obviously we standardize everything to the white male, but it then lowers these targets. So it's about, I want to say it's about 23.5 is the upper limit for overweight, and 27.5 is obese, whereas in white people it's 30. My point is that even if you have a normal BMI, you can still have type 2 diabetes. And this is due to something called, or the theory called, your personal fat threshold. And this is why there's obviously so many things in life where you should not compare yourself to others, but this is one of the other reasons as to why comparing yourself from a physiological point of view to someone else and giving them the exact same treatment is not always going to come out with the best results. And the reason this is a thing is that, like I said, there were some people who actually were borderline anorexic and they have type 2 diabetes because they have a low personal fat threshold. And when I was talking before about someone who is obese, where you can see them physically and they have a lot of fat underneath the skin, you know that a lot of their fat is under the skin and it's not really caused or leading to visceral fat, which is fat around the organs and within the organs. So in someone who is thin, you could potentially have a lot of fat within the liver and pancreas, which is then causing type 2 diabetes. And that is something I just want people to be aware of, is that I have had patients who have had this and the management remains the same. You just have to reduce your weight and improve your activity to a greater extent than someone who is less inclined to this personal fat threshold. And the study, if you want to go into it, is, I think it's called the Retune study. So that is one that you can look into to prove the fact that you can have diabetes at normal weights and you can still improve it by obviously enhancing muscle mass and reducing fat mass. Now, the other thing that I wanted to go on to, fat threshold I've gone through, and yeah, there's obviously a lot of things that I can go into in terms of complexity. I'm not going to at this moment in time because I'm going to look at any of the questions. So obviously, thanks for asking them. So I'm going to go on to a few of them. So, is type 2 diabetes curable and genetic? If my dad had it at 60, will I have it? So this is a good question, actually. Is it curable? So like I just said, then the term that we use is remission. And that is because in a lot of patients, a condition has the ability to come back. So that's why we don't like to say cured, because that sort of gives a finality over a statement, over a diagnosis. So we say remission, but it can be put in remission. And that evidence, like I've just went through, clearly solidifies the fact that I can do. Now, the one thing I was going to say about genetics, when it comes to diabetes, the main one that's caused genetically, it's actually a bit more complicated. There are genetic forms of diabetes, like I've got one called glucokinase moldy. But when it comes to the two main types that people are more concerned about, so type 1 and type 2, type 1 is heavily genetic. Type 2 has genetic traits, but how would I describe it? I would say type 2, when it comes to genetics load the gun and lifestyle pulls the trigger. And I think that's the best way we can say it, because with genetics, for example, that is where your personal fat threshold comes into it. So if you are someone who is, like I just said, on the leaner side of things, so let's say if someone like my stature were to get type 2 diabetes, there is a good chance that their genetics have heavily influenced that because they have a low fat threshold. And when I mean fat threshold per se, it is that when fat eventually goes into the liver, this is when it becomes an issue. So when it comes into the liver, it can impact so many functions in the body, because the liver is essentially the main coordinator when it comes to metabolism. It's a big thing. Now, one of the things it does when it has a large amount of fat is it will also release fat. When that fat has met its threshold in the liver, again, for me, it could be, these are arbitrary numbers, it could be 1 kilogram for me, whereas for someone else, it could be 10 kilograms. But once I've met that threshold, and both of us have, that fat will go to the pancreas, and that is when you get a reduction in insulin. And that's when you normally lead to other things, type 2 diabetes. So when it comes to the genetic side of things, I would say it's more to do with the fact of your fat threshold. If you come from a family, again, you can always have a low fat threshold, but usually if you are on the larger side of things, so you have only just acquired type 2 diabetes and having a BMI, let's say, of 33 plus, there's a good chance that it is largely lifestyle driven and less genetics, because your body has had a good ability to get to a high weight, a high fat mass without the need for metabolic dysfunction. So that's one thing I would say. So can diabetes lead to pancreatic cancer? Good question. In terms of numbers and stats, I'm not the best on this. Pancreatic cancer is not something I tend to see a lot of, but technically, if you've got type 1 diabetes, potentially could do. If you've got type 2, like I've just said, you're having a lot more fat put within the pancreas. Cancer, by definition, is abnormal growth. and lack of regulation. So technically it could do, but I wouldn't be 100% certain on the numbers relating from type 2 or type 1 diabetes. What are pre-diabetic tests I can get? Pre-diabetes is the same with any diabetes. So you can do, there's a few tests that you can do. So there's the HbA1c. So for non-diabetic, you are looking for less than 42 millimoles per mole. 42 to 48 is what we would call pre-diabetic. It's a bit of a, I don't know, it's a bit of a loose term, pre-diabetic, but that's what we use, or what would we call it? Impaired glucose tolerance. That's a fancier word. And then 48 plus is where we would have diabetes. Now, HbA1c is a good marker because it allows you to look at your blood sugars over the past 3 to 6 months. The reason being is that it is measuring the amount of sugar attached to blood cells. And blood cells have a lifespan of 120 days, give or take. So by the time they've been a new fresh batch has come in, you've got enough time to look at how much sugar is being attached to it, and then we can sort of draw a conclusion from that. So there are obviously issues with this. If you've got blood disorders, such as you produce more blood cells, or you have a reduction in clearance of them, or you've got issues with other things, then you can have false negatives and false positives with that. But by general, that is a decent test to have. So that's one test, is your HbA1c. The next one, which a lot more people have access to, it's basically the same type of test. However, they are blood glucose monitors. So you can do the finger prick, which will basically prick your finger, give a bit of blood onto a testing strip, and that will come up with a reading. Depending on what time of day you have that reading, will give you a different outlook and allow you to be guided along your treatment. So ideally, if it's first thing in the morning, you want it to be less than 5.6 millimoles per litre. You're testing me now because I need to remember these numbers. I used to do this religiously when I was younger, obviously, when I was getting diagnosed. If you have a level above 7, this is first thing in the morning without any food, you have got diabetes. In between is your pre-diabetic. Obviously, you don't want this number too low, because too low of a blood sugar will lead to comas and put you into another set of risks. However, this is the most common thing. After a meal, so you normally base it on timing. So 2 hours after a meal, you want it to be less than 11.1. I hope when I watch this back, I've got the numbers right, but pardon me. That is what you are aiming for off a finger prick test. Now, you can do all this on an easier level with continuous glucose monitoring, and they are the ones where you've got a circular disc on the back of your arm, connects to your phone. It gives you a greater real-time, evidence-based plot with all your sugar on it. That is the best thing for me. I think that is the one that if you've got access to that, they are very expensive. There's a brand called Freestyle Libre. They do a Sensor 3 Plus now, I think it is. I think you're looking at, I want to say £60 for two of them. 60 to £120. It's in that ballpark anyway, so they are very expensive. But that is one thing you do. And the minimum time you would repeat them is about 3 to 6 months. That's what I would do. Lee, can I ask a lot of questions? I got from Google that I really want to know. Yes. So the pancreatic cancer one, like I said, that is one thing that I don't actually know off the top of my head. But in theory, I mean, if you do the things that I went through here, there's a couple of things that I didn't mention, which I'll bring up in a minute. If you go about exercise and improving your diet and muscle mass, like I said, then there's a good chance that you're going to have greater metabolic function, greater general health, and a reduction in all-cause mortality and cancers, because a lot of cancer comes from the inability to use energy. Insulin, again, is central to a lot of cancers. So if you can control it, then it's only going to be better for yourself. What vaccinations should I have? Right, so vaccinations, I will do in another video, because there is something, I think it's this one. If you want to look into vaccinations, there is something called the Green Book. The government have released it. It's basically where every vaccine gives out all of its evidence, all the trials, and is where we look for, as clinicians, any advice on how often should we give the shingles vaccine, how often should we give the flu vaccine, what groups are more at risk, and all them things. So the Green Book is one resource that I would use, but I will do a separate video on vaccines because I have not looked at them for a long time. I haven't looked at immunology per se in its own right for a long time, so definitely something I will be doing. What are the early warning signs of nerve or kidney damage that I should look for? Nerve damage, you have got things. So when it comes to nerve, you normally, again, these are non-specific, so this is not medical advice, like I said at the very beginning, and put in a disclaimer. However, take these with a pinch of salt because a lot of conditions or symptoms in life are very, very non-specific. But when it comes to nerve, you can have something called paresthesia. Paresthesia, anyway, I was just trying to spell it. That is basically pins and needles, so the tingling sensation. A lot of people get it if they sleep on their arm overnight and wake up in the middle of the morning and it's feeling tingling, but that is one sign. You've also got the fact of a loss of sensation. So if you can stand on a stone, for example, in your shoe for an hour, that's a big thing with diabetics. That's why you get foot checks to make sure your nerves are in good function. But if you are driving, I'm just seeing a car, ignore that. But if you are walking with a stone in your shoe, then there's a good chance that you've lost sensation. That is usually nerve damage. A lot of people will feel a burning sensation. And a lot of people, if I can speak, will feel a lot of pain. So they're the first things when it comes to nerve damage that I think of. Loss of sensational function, burning, pins and needles, pain. They're generic ones. Again, you need to tie everything in. But some things that you need to be very careful of are your neural function, your nerve function when you are diabetic. Because like I said, because you have poor wound healing, especially the further away you get from your heart, a lot of people do have diabetic foot infections, which leads to a lot of complications, bone infections and amputations. When it comes to kidney damage and you do not have any access to any, obviously blood testing is the gold standard along with ultrasound. These are ultrasound scans. They are the gold standard for any kidney damage. You have got tests such as urine, albumin, creatinine ratio. Basically, albumin is a protein, pardon me, that's released by your liver, produced by your liver. It's something that should stay in your blood. However, if you are releasing protein and albumin within the urine, it shows that your kidneys are damaged in terms of the word is called fenestrations, but it's basically you have little gaps within your arteries by your kidney, allowing stuff to pass through. So like toxic products, waste products to make urine. However, they should only be a certain size. And if they are too big and they allow a protein through it, that is when you are at a risk of kidney damage. You've also got the simple one. How many times do you go for a wee? Urine output. So there are different things and you can Google it. You can look at something called AKI and you can look at urine output. But the top of my head, it is usually if you have a urine output of, I think it's 0.6 mils per kilo per 6 hours, I think it is. If you have less than that, so if you are 100 kilograms, you should ideally have more than 60 mils every 6 hours. Otherwise, your kidney is in some form of injury. And 60 mils, for context, is a double shot. So you can see that you should be producing more urine than that. But they're the main ways that you can look into whether you have potential kidney damage. There are other blood tests. Kidney clinics will do testing for you. However, that's one that you can do. So let me have a look at these. How often do I need an eye and foot exam? If you are diabetic, every year. If you are not diabetic, then it would just all be based on, and you've got no medications that require you to have them exams, it would just all be on your own personal preference. And it would be if you feel any difference within your feet or within your eyes and vision, that is when you would obviously seek a bit more. Now, can I recommend a nutritionist? Top of my head, who deals with yourself or adult patients? Not really. The NHS does offer them. And I think there are a lot of things on Instagram and YouTube at the moment anyway. If you go on there and you just adapt a whole food diet, adopt the whole food diet, that is the biggest return that you're going to get. If you eat real food and eat for your energy requirements, then you're going to be a lot better off than where you are now. That is the diets are pretty simple. Obviously, it becomes more complicated when you have kidney issues or you have dietary insufficiencies, such as you are vegan, for example, and you can't get a full amount of B12. These would all become a bit more complicated. But in general, you should have whole foods 80% of the time, and you should have protein, at least 1.6 kilograms. No, don't have 1.6 kilograms. That is a lot. 1.6 grams per kilogram each day. You want to have fiber, about 30 grams each day. And then other big things that you want, or main things. And then just eat for your energy demand. So obviously I do this on a regular basis. If I am doing more activity, I can afford to have more food. If I'm more sedentary on some days, then I can't eat as much because that will just go on as stored fat and it is not beneficial for my body. Right. So that is that. What should my blood sugar levels be before and after meals? So that's what I went through before. So ideally before a meal, if it's fasting, you should be less than about 5.6 millimoles per litre. And then after a meal, 2 hours, it should be less than 11.1 millimoles per litre. I will double check that, but I'm pretty sure that's that's in the right ballpark. What is my target HbA1c goal? Target HbA1c goal. So for anyone who is not diabetic, less than 42 is your goal. Ideally, it should be between, give or take, 20 and 42 is classed as normal. However, if I had to pick an ideal amount, then I would be aiming for your 30 to 37 is where I think you would get the best return. Some people naturally have lower levels. For context, last time I done mine, again, I've got diabetes, is 46. The funny thing is that mine is going to be inherently high for basically the rest of my life because of the enzyme that's affected. No matter what I do, it doesn't seem to really budge, even when I go on full fasting diets. There's a few things I've got to try. Now, let's see, HbA1c is 37. So HbA1c of 37 is perfect. It is well better than mine, and that is not bad. But diabetes is something I worry about because of my dad. That's fine. I feel like I constantly have mostly after eating a heavy stomach feeling because... So this is one thing I did want to bring up. There was a study done within New Zealand and I looked at it earlier on today and I obviously knew the reasons why, but I actually didn't fully know the benefits of doing so. So when you are having a meal, let's just do a very simple thing. So here is your intestine and stomach. I'm going to do that. Stomach/intestine. So food comes in and it will be broken down into carbohydrates. You will have fat and you will have proteins, amino acids. Then after that point, your body, via the help of GLP-1 mainly, which is why it is such a wonderful drug for a lot of people. However, you can do it naturally. It's a natural hormone. So via GLP-1, you will release insulin, obviously the major hormone in energy balance within the whole body. I think that's the most crucial hormone. And if that's not working, then I feel like a lot of health inequalities come from it. So once you release insulin, your body wants to store all of this because it's basically saying, we've got energy coming in. Why don't we put it somewhere? Now, one thing that I actually didn't fully know is on your muscle, there is a transporter, which would normally help fat go into it. That's a simple way of putting it. However, after a meal, insulin stops this transporter from working because it wants sugar to go into the cell first, because the whole goal is to reduce the amount of carbohydrates. Now, this is why a walk after a meal, and this is only 10 minutes, it doesn't have to be brisk, it is a 10-minute walk, is so beneficial for your health is because you are using up the energy that's just come into your system. And when you are doing so, you are reducing the amount of energy that's going to be stored within anything. So a 10-minute walk after a meal versus so I'm going to put post meal, versus a 30-minute at any time of day, at any time. Now, they did a study, it was 41 people, granted, not many people. However, when you had a 30-minute walk at any time of the day, which I'm not trying to tell people not to use, you should still walk and try and do as much basal activity as you can. However, if you are going to choose a time of day to walk, you should do it after your biggest meal. And that's because they had a 12% reduction in blood levels of sugar after the 10-minute walk. And that is because, like I said, the muscle is using sugar as opposed to fat. Now, when you done this after your biggest meal of the day, it ended up having a 22% reduction, which is usually your evening meal. So that is why it becomes so effective. So yeah, get up and walk after your meal. It is a simple thing to do, and it's probably why a lot of people who, and I'm one of them people where you look at certain people in society and think, how have they got around being overweight or not going to the gym or not looking after the diet too well? And it's because they do little things without this happening. So I'm going to pick on builders here because, like I said, family are in construction, so I can say it. But when I used to work with them on a Saturday, you'd have, if you were able to have your dinner, you would have your dinner, and then within 5 minutes, you are back up doing basal activity, whether that's lifting flags, stoning up some cement, whatever it is, sand, you are doing basal activity. So without them knowing it, they're using that energy and reducing it from being stored, which is why I feel like a lot of people who have technically bad lifestyles or poor habits are offset because they're doing other things subconsciously. Now I'm just going to have a sip of water and have a look at the next couple of questions. So let me have a look. Okay. There's actually quite a lot of questions, but they're all actually really good. So, wow, I didn't realize where I was up to. I feel like, okay, right, so I'm up to this one. Proposed that type 2 diabetes is caused by excess fat accumulation. It suggests that two organs engage in self. The liver and pancreas, yeah. So that's the twin cycle theory. You can look into that a bit more, but it just supports the fact that energy excess within the system will lead to poor outcomes when it comes to metabolic health. How does type 2 diabetes turn into type 1? It doesn't. Type 1 diabetes is autoimmune destruction of the beta cells. Type 2 diabetes cannot turn into type 1 unless you have a genetic predisposition to causing damage to them cells. If you mean how do type 2 diabetics go onto insulin, that is because their body is so resistant to the effects of insulin through largely poor lifestyle that they need an extra boost to basically get all the energy within the cell. So that is where it is. Years ago, it used to be called insulin dependent and non-insulin dependent diabetes, but that got changed because, as I've just said then, type 2 diabetes can be treated with insulin. So that is that one. If you are in pre-diabetes, can you cure before it turns to full-blown? Yes, and that is the best time to do it. Like I said, even in type 2 diabetes, the earlier on you start, the better your outcomes. With pre-diabetes, it shows that you have an ability to reverse that probably to a greater extent than anyone else. So definitely something that you should be looking into. So next one. I am obese. So what is my likelihood of developing diabetes versus skinny? And can skinny people have diabetes? Yeah. So skinny people, like I said, it's all dependent on your fat threshold, how much you can store within your liver and pancreas. So they can have it. If you are obese, you are greatly at an increased risk. I don't know the exact stats off the top of my head. However, the large majority of people who have type 2 diabetes would be classed as overweight or obese. I would probably say at least 95% of people would be classed as overweight or obese. So that gives you an idea of how prevalent it is with obesity and overweight. How does my urine ACR look? Where was your urine ACR? With urine ACR, by the way, so if anyone, like I said, that's the amount of albumin within your wee. So that is basically measuring how much protein is coming out. So, pardon me, when it comes to what your level should be, ideally it should be less than 3. And then we go into 2 categories. Testing me today, whether I know all my categories. So years ago, we would just base chronic kidney disease, CKD, based on your filtration rate of your kidney. But now we use your urine ACR, which is the amount of protein that you're weeing out, along with your kidney function. So we have, for ACR, you have intervals such as 3, then 30, and then I think it is 300 are the sort of things. Ideally, you want it less than 3. But this is when we start looking at it a bit more, and then above 30 to about definitely 70 is in there because that is a diabetic marker or guideline. We then start to treat you with certain things and put you on preventative therapy. So we want it less than 3 in the large majority of cases. And then when you pair that with your kidney filtration, so ideally you want it more than 90 mils per minute, you will get kidney readings such as you can have stage 3A, for example, and that is pairing up certain values within each one. But the long story short is you would like your urine albumin ratio to be as low as possible because it shows that you are not having any physical damage really within the kidney. It's not the only thing it means, but it is a good thing. Should we consider an SGLT2 inhibitor for its cardiorenal protective benefits? Good question. Now, for anyone who doesn't know what an SGLT2 inhibitor is, it stands for sodium glucose like transport 2 inhibitor. We have a couple of these transports within the body, but a bit of physiology here. So when you've got your kidney, which looks doesn't look like that. If you look like that, then you would obviously need a lot of help. But within the kidney, you have little units called a nephron, and that is basically what is the functional part of a kidney. It's made up of thousands, maybe even millions of nephrons, and it looks like this. So it's basically, and then that will eventually go into your bladder, and that is where we make your urine. Now, along this, we will put water into the nephron, and that is what eventually makes the urine down here. We absorb stuff across it. Now, here is where the SGLT2 stands. And basically, when you are diabetic, like I've just said then, when diabetes was first discovered, it was about, I think it was 1500 BC by the Egyptians, and then Indian physicians actually brought it to light again in about 5 BC. But the meaning of diabetes mellitus is to siphon sweet. So basically, you are producing sweet urine. And that is because when you have poorly controlled diabetes, you've got a lot of sugar that's within your blood, which comes into the kidney. And then because there is so much sugar within the kidney, it can't absorb it all back. So basically, your kidney is letting all this water go with the sugar. And that is why a lot of diabetics lead to a lot of urination. They feel thirsty all the time. They feel as though they've got no energy because they are releasing a lot of sugar into the kidney and into their urine. If you inhibit this from a diabetic or type 2 diabetic point of view, you increase the amount of sugar within the kidney and you increase the amount of water that we remove. So obviously, why is that a good thing from a diabetic management point of view? Well, when you reduce the amount of water within your cardiovascular system, so you've got your heart, you've got the arteries, you've got the tissues, and then you've got the returning veins. If you reduce the amount of blood within this system, you reduce your blood pressure. The heart, to a certain extent, likes lower blood pressure, so it is protective of the heart. And then the other things that you've got which are beneficial is that by reducing the amount of fluid coming in, it will reduce the amount of force going through the kidneys, which then classes it as renal protective. There are other things, and I think the mechanism is too advanced because not many people actually understand it themselves when it comes to SGLT2 inhibitors, but that is why it is now first line with metformin. So people may be aware of this drug, and it's called dapagliflozin. For diabetes, we normally give 10 milligrams each day. And anything with flows on the end is an SGLT2, and they are usually first line at this moment in time with metformin for type 2 diabetes. So yes, if you've got a high risk of heart disease, family history of it, you should definitely be put on that by someone. So what's the plan for protecting my metabolic memory? What do you mean by that per se? So the genetics versus lifestyle explanation was amazing. Okay, thank you. So like I said, genetics load the gun and lifestyle pulls the trigger. So there is a lot, and the reason why I say that is because when people use the word genetic, they feel as though they are helpless. That is it. Sort of the outcome is not in their hands. However, with type 2 diabetes, it is definitely within your own hands in the large majority of cases. Let me see other questions. Can diabetes Can the diabetes risk in heart disease and other risk be just as dangerous in pre-diabetes? Your pre-diabetic patients will have an increased risk over someone who is not. However, the risks are not as full-blown because insulin's not as resistant at that point. That's probably the best way of going about it. Am I eligible for a prevention program pre-diabetes on the NHS? No, I don't think so. So when you do a review, ideally with the nurse or whoever it is doing your diabetic, pre-diabetic review at the surgery, they should be going through a lot of these things. And it is usually left on a 12-monthly basis. And hopefully by that point, you've reversed it. But like I said, not shaming any nurses or anyone out there who carries out diabetic reviews because the sheer volume is too great to be specific. However, and also the guidelines and the education that's given to health professionals isn't substantial enough to provide a deep level of workout plans or dietary interventions. However, there could be greater interventions at that level that would lead to greater outcomes. That's why I try and advocate for it as much as possible. How much weight do I need to lose? Even they always say 5%. Any weight that you lose is always good, apart from if it's muscle weight. When you say weight loss, we always want to lose fat mass. And when you lose weight, you want to make sure that your lean mass doesn't really come down above 20%. So if you lose 10 kilograms, you would want only 2 kilograms of that being related to lean mass. Any more, it becomes a point of, is it beneficial for the body because we're losing the metabolic tissue of the body? And yes, there are benefits because you're losing fat, which is going to put a lot of stress on the joints. However, you need to factor in that you need to be preserving lean mass as much as possible, which you can do by lifting weights, body weight, weights in the gym, and eating enough protein. Right, let me see what is next. So, what are the best ways? Okay, there are quite a few. Would you recommend? Can diabetes medications mix with other medications? Yes, a lot of medications can. You just obviously need to make sure your kidney and liver are in good function and make sure everything's being treated to you as an individual patient. A lot of patients who have type 2 diabetes will have something called polypharmacy, which is like what it sounds. Poly meaning many, pharmacy meaning medication. So a lot of people will end up having a lot of treatments. Can diabetes, yeah, I've said that one. Would you recommend NHS dietitian over private? Is there any difference in qualifications? Now, a lot of things within UK healthcare is quite funny because a lot of the private physicians that you see will be NHS by day. We've got a couple of friends who are dietitians, however, they specialise within paediatrics and they do private work outside of the NHS. In terms of are you going to give a better level of care? I think you've got different motivations and different environments. So if you are a private patient, one, you are paying money, so that shows engagement, as opposed to it's a compulsion for me to do a review on someone because they are a part of the NHS. So you'll probably get more engagement from the patient, more from the physician, so that you're going to get a better outcome there. You normally have more time allotted to you because it's usually on an hourly basis. And there is less hoops to jump through in the sense of you don't have to really adhere to as many guidelines because you are not working within a set environment. You are just going off clinical evidence mainly. So I would always say private are better, but not because the physicians are better, because they're basically the same people. It's just that you have a greater environment for that. Now, does diabetes increase the risk of vitamin deficiencies, and should I look into supplements? Yes, diabetes does increase the risk, and it's mainly due to, which way am I holding this? It's mainly due to metformin. Well, there are other reasons, obviously, depending on your diet anyway. If it's low in fiber, you're going to have vitamin deficiencies. However, metformin has a tendency to reduce magnesium and reduce vitamin B12. Now, this one is becoming more and more of a talking point within surgeries because about 10% of people who are on metformin will experience low B12. And when you are then putting that together with the fact that people are on acid therapy, so PPIs, omeprazole, which further low B12, then you are going to have a lower level. So you should always be getting checked on an annual basis for vitamins and minerals, and you should make sure that your diet is fully balanced, which is why I say to aim for at least 30 plants a week and 30 grams of fiber each day. So that is that one. How does managing blood sugar affect my muscle recovery or joint health after I exercise? Okay. How does managing blood sugar? I mean, from a simplistic point of view, like I said, blood sugar being at high levels will just damage the vasculature anyway. And when you've got high levels of blood sugar, it is stimulating insulin to certain levels. It is not allowing your body to use other fuel sources to make you more efficient. There is so many things that are involved within it. So blood sugar being controlled to a better level and increasing insulin sensitivity just affects your overall health in such a positive way. So that is probably the simplistic answer. Sleep apnea is common. Could that be why I'm feeling so tired? Sleep apnea is usually due to excessive weight around the throat, which is usually not a cause of diabetes, or definitely not what I know of. It would mainly be due to the fact that patients who are type 2 diabetic are usually overweight or obese. Having more mass there leads to sleep apnea. So the sleep apnea would be as a consequence of the weight loss and more coincidental that they've got diabetes. That's my point of view on it. Again, losing weight and improving muscle mass will improve across the board. That is the number one treatment for this by a country mile. So, what are the best ways to manage cholesterol levels when you are managing glucose? Good question, because everyone's favorite medication, so statins. Now, when you are diabetic, you're basically, if you're type 1 diabetic, there's a bit of criteria to jump through. If you've had diabetes for over 10 years, you are over 40, you have, I think it's advanced kidney disease, whatever it may be, you are then advised to go on a statin. And if you are type 2 diabetic and you have a risk of about 10% when it comes to heart attacks and strokes, you are then also advised to go on a statin. However, statins have a lovely history with inducing muscle pain, potentially reducing muscle mass. Again, I need to look into these a bit more because I don't want to advise people in the wrong way. And they also increase, ironically, your blood sugar levels. I always annotate it as BMs, and that's what we do in healthcare because there was a company in the 90s, can't think, it was like Bayer, something else, a German company who made a blood glucose monitor. So if you ever see BMs on a discharge or on clinical letters, it's normally relating to blood sugars. It used to confuse me. But the point is that we would normally go for this for lowering cholesterol. And if your cholesterol is still too high, despite all the things I went through the other day, where it's about diet and exercise, I would still probably use a statin, but it would be a very, very low dose. It would be potentially one called a rosuvastatin. It's quite hard writing when you're not looking at it. And then I would probably pair it up with something called a ezetimibe if it was still too low, still too high, sorry, and not in range. But that is a good one because a lot of people can have adverse effects from statins and ironically give them more of an issue. But again, everything with medicine and life is a risk balance. Is the risk of you having a certain outcome more detrimental than you having the risk of something else? And that is basically what we do in life. Is the risk of us driving to the shops greater than us walking? And the risk being that you could have a crash in a way, you could have a blowout, or you could walk there, but then you could also get into a fall, you could have a fight on the way, or there's so many things that you need to weigh up. And for me and a lot of people, it's easy to drive to the shops because you save a lot of time. So that's the risk benefit in reality. Now, I've heard diabetes and blood pressure are closely related and linked. Should I be focusing on my cardiovascular fitness? Yeah, zone 2 is what you should be doing along with lean mass. They all interlink, and that is why I try and help people to understand these things, because the more that you understand how closely all these things are related, you will see how you can solve a lot of issues without letting things become too complicated. Right. Let me see, because some of these, right. Since we're talking about blood sugar, I was wondering how it impacts heart health long term. Oh, I mean, diabetes, like I said, because it damages vasculature, increases the environment for plaques, atherosclerosis, heart attacks to all occur. So it's not beneficial. I think that's the best way without repeating too much of what I said. How might it affect my mental well-being, and what support resources are available if I feel overwhelmed? With regards to mental health and resources, there is always a local community. There is always, like in Wigan or Greater Manchester, we are with you. There are all these charities that you can go to. With regards to diabetes and mental health, anyone who has a lot of conditions which can cause poor health, diabetes, heart attacks, strokes, you normally feel low in mood because you're not functioning to the levels that you once did, or you are not able to do certain other things. So that is where mood and diabetes come in together. In terms of, does diabetes, in the way that insulin and blood sugar works, precipitate certain mental disorders? There's obviously a link with dementia and Alzheimer's because of its insulin and the insulin relationship. However, in terms of depression, it's usually due to the fact that you are having a lot of medical conditions which are reducing your quality of life. Your dad went from type 2 to type 1. So type 2 to type 1. So I actually had the oldest patient I've ever had this week who has been diagnosed with type 1. They were 41 years old. So it's not like you are going from type 2 to type 1, because in type 2 diabetes, let's say this is the pancreas here. Usually in type 2 diabetes, these cells here are called beta cells, and they are of the islets, islets of Langerhans. Anyway, that's what they are, and these are the ones that produce insulin. So they produce insulin, and it goes into the common bile duct, it goes into circulation, all these things, it goes out. Now, if you have fat come in, the fat will get stored within these pancreatic beta cells, and if it goes from this round shape here, it will change, and it's a process called de-differentiation. So it could change into a shape like that. And basically, the cell doesn't have the ability to do what it once was able to do, which was release insulin. So that is why you have a reduction in insulin here. And that is what leads to a decreased output. And in some patients will lead you to have an insulin being given in an injection. Now, with regards to type 1 diabetes, these cells are completely being destroyed by your immune system. Whereas in this, if I remove the fat out of this cell, it will go back to this type of cell. And if you've not exhausted it, then you will still have function. So that is the probable reason as to why someone converted from type 2 to type 1, was that it was misdiagnosed in the first place, and they were more likely to be a slow, progressive type 1 diabetic. That is the more, well, that is the greater likelihood anyway. Is there any evidence of there being an optimal time for high intensity exercise in terms of time of day and time of week? I mean, with HIIT, so obviously you've got high intensity interval training. That is basically what it is. And then you've got different types of a Tabata and all them things. However, I would probably do that no more than 2 to 3 times a week. That is probably the maximum, because you get nervous system fatigue, and it only really works on your energy system where it's using sugar and glycogen and pyruvate and lactate. That's why you need to train a lot of things to make sure that you are metabolically healthy. In terms of a time of day to do it, you've got a couple of things in which you can look at it. So if you do this fasted, you are going to have potentially less glycogen within the muscle. You are going to have less access to nutrients. so your output may be lower. So there's that point of view of if you eat and then maybe wait an hour and then go and do a HIIT activity, you're going to have a greater output. And if it's all about improving strength performance, then you are probably going to eat an hour to 2 hours before you HIIT. I mean, in terms of time of day, what would be the best time of the HIIT? It would be better earlier on in the day. And the reason being is that because of the type of training is very stressful, it's probably going to release cortisol and other things that are going to keep you heightened adrenaline. So if you do that later on in the evening, so normally it's in the morning, if you do it later on in the evening, you could still be very, very pumped before you go to bed. And then you're just going to have a poor quality of sleep. The real answer is to do it anytime, because to do exercise is obviously very beneficial. However, if you are going to pick a time, I would say as early on in the day as you can, because it's going to affect quality of sleep. And you want to probably do it, in my opinion, probably an hour and a half after you've just eaten some food. Neither slides being thank you. How often should I be getting specialized screenings for my eyes and feet? And who do you refer to? Again, like I said, you've just got to do it. If you are not diabetic, you've just got to do it off how you feel. How you would do it, you wouldn't be able to get it through the NHS because there wouldn't be any reason for you to do so. So you would have to go and get your eye test done through an optician and go and pay privately for a podiatrist to do a foot test. So how are there any newer medications like GLP-1 agonists that would be appropriate? GLP-1 are probably the better ones at the moment, and there is an old medication for type 2 diabetics which is not used anymore because a lot of people are scared and don't really understand how it works, and it's called pioglitazone. It's something that we don't really talk about too much when it comes to pharmacology. However, these are one of the only truly insulin sensitizing drugs, meaning it changes fat from inside the liver and pancreas and puts it towards the fat outside of by the skin, essentially. So people say you gain weight and that's a bad thing. However, it's shifting, it's redistributing the fat and making it more metabolically safe for yourself. But it's not new, it's probably like 30 years old. Now, what's your opinion on CGM versus traditional? CGM every single day of the week is the best thing because you get real-time insights. You've got less chance of anything being on your finger, such as fats and sugar, to interfere with the readings. CGM, it's just very expensive. Now, if your diabetes turns to other diabetes, does that make your life significantly more vulnerable? Of course, always does. Diabetes is a condition that we should not take lightly, and a lot of people do because so many people are diagnosed with it, and I don't know why we do not give it more precedence, really. But it is a very severe condition and something that we need to take a lot more care with. So let me see this one. If your genetics in your situation mean you will get it no matter how healthy you are. Yeah, so okay, I'll go through, even though this is how to put type 2 diabetes into remission. So this is my diabetes. It is called glucokinase moldy, which is maturity onset diabetes of the young. I got diagnosed this when I was 9. So basically, when you've got sugar that has just come in, so this is in the blood. So this is within your blood now. So if you've got sugar in your blood and you want it to go within a cell, let's say the muscle cell wants the sugar. So the sugar goes in, and I'll have to make this a bit bigger actually. When that sugar goes into the cell, which I'm going to draw here as a big, massive thing, the body obviously wants to keep that sugar in the cell because it would be of no use if the sugar comes in and then we just let it go quickly because we've sort of accounted on that sugar. There is a process where we add a group called a phosphate, which you don't need to know, but basically putting that phosphate on it puts a tag on it to say you can't get out of this cell now. And the thing that does that is called hexokinase and in the liver, and glucokinase basically everywhere else. Oh no, hexokinase all the way around. Either way, that enzyme causes that reaction to happen. Now, this is the part that's faulty on me, and it does work. However, it takes a large amount of sugar within the blood. So this is the average person. 1 molecule of sugar would initiate that response. Mine is, let's wait until there's about 3 there. Oh, okay, we'll take 1 in then. And then at that point, it will then use them all. But my levels of blood sugar are usually higher because of this process is delayed. And when it's also within the pancreas, which is where this also happens, you need the sugar to be tagged for it to then release insulin. And when mine's taking a lot longer to be tagged, then obviously I'm reducing the amount of insulin until later on in the day. So that is where my genetic one come from, and it was a very hard one to diagnose. And it is a pain in the backside because no matter how much I reduce sugar and all these things, it doesn't want to budge, basically. And it would be a bit too complicated to go into. Right, now, do you see patients in work that ask for help with diabetes but don't want to change their lifestyle and you want to fix without them trying to help themselves? A lot of patients, like I said, there are in the UK over 5 million people with type 2 diabetes. I would say out of the 5 million, very few, I would probably put a percentage on maybe 5% actively want to engage with lifestyle changes. And I think it's just because we're so good at using medication. And that's the issue. I always come back to the fact that diabetes is a disorder of fat. And when you treat it as a disorder of fat, that is when you get the best outcomes, because if you are measuring blood sugar, so like I said, this is a cell and you've got sugar within it, and this is your blood. So in type 2 diabetes, for example, you've got loads of sugar in the cell, but it's leading to a lot of fat. The body can't use it, and it's basically sitting there. It's going to spill out into other things. But because we're so focused on the amount of sugar within the blood, if this is low, then we're saying, okay, that's good. When in reality, all we're doing is giving you treatment to say, well, we'll just kick a bit more sugar into here, even though we can't use it. And because we're measuring this, and that's low, that's fine. Obviously, that is why I focus on fat, because if you solve this, you solve this, and you solve this at the same time. So the question was, yeah, so when it comes to treatments and pharmacology, because we use blood sugar as the marker, when we come up with insulin, metformin, glycoside, all these medications, because it's showing that your levels are low within your blood, to a patient, that's obviously a satisfactory result, when in reality we should be measuring liver fat and pancreas fat and all these other things, but that is a long way from happening. So yeah, a lot of people need a lot of help, and I always tell people the biggest thing with diabetes, type 2 diabetes, even type 1 diabetes, you will always be on insulin. However, there have been cases where you can manage type 1 diabetes for a short period of time with just exercise alone. That is how powerful exercise, lifestyle, diet is, and especially the fact that diabetes type 2 is a disease of abundance, and it's grown from 30 million in the 80s to 840 million at this moment in time, shows you that there's not really been that much change in terms of genetics. It's just been the fact that we've got more food and less activity than we've ever had in human history. So, is it possible to get diabetes non-genetic under 30? Yes. I have quite a few patients who are under the age of 30. I've seen, obviously, this is type 2 diabetes. You mean in type 1 diabetes, you can have basically from birth. It's all about how quickly you are destroying your cells. But with type 2 diabetes, I have quite a few patients who are in the 20s, and that is due to the fact that they are metabolically unhealthy. They've got a lot of fat, and it's just growing and growing. And the only issue is, it's a good thing, but it's not, because GLP-1 pens have come out and they are solving a lot of pre-diabetes. And my issue is that because people are not changing their lives when they're on this, when eventually the pharmaceutical companies, which they've got every right to do, increase the price of this, that then makes it unobtainable, and patients are basically going to be as unhealthy as they've ever been, because they've been reliant on such a special drug, really. And it's only going to get harder to come off that drug because they are becoming better. Hi, good to see you. So it's possible to reverse pre-diabetes or after? It is. Is this recorded? Yes, so this will go on to the main YouTube channel after it. But when it comes to reverse, like I said before, we use the term remission because everything has the ability to restart. And when you say it's cured or reversed, you've basically given the tag that nothing else is going to happen from it, and it's sort of like a finality, it's a statement, and we don't want to really hold ourselves to it. It's like saying, I don't know, you get some work done in your house and they say it's virtually guaranteed that it's not going to leak in the house. They don't say it's 100% guaranteed, because if it does and then they come back for you, you've got a viable lawsuit. But yeah, when it comes to reversal, it's all due to energy. And the main things are, if you want to look at it in your own time, obviously I've gone through it at the very beginning of this live. However, there are a few things. There is something called the twin cycle theory. So that is the first time where we actually, this was about 2008. This was one of the first times where we saw that fat was a big component within diabetes, and that energy abundance is the biggest cause. They then done further trials, and they done one called the direct study, and they basically reduced the calories of these people down to about 800 calories per day. In those people who lost a lot of weight, so in those who lost 15 kilograms plus, 86% of them maintained no diabetes, so they were diabetic free at the 1 year mark. And then I think definitely at 2 years, it was still over a third of the population who were in that study group were diabetic free. And then this obviously reduces with the amount of weight loss that decreases. So at 10 kilos, I think about 57% of people went into remission. So it goes to show that if you reduce more weight and become greater with your lean mass, you are going to have a greater outcome at reversing that, or putting it into remission. Like I said before, type 2 diabetes is not a disease of just the obese. It is also for those who have issues with where they store fat. You can have very lean people who are unable to store fat under the skin, and they will put their fat into organs. This has been proven by transplant of fat with mice, where they have a mouse where it basically has no fat. It induces diabetes when it's basically anorexic, and then it transplants some fat onto it, and then the diabetes is put into remission. So the one study, yeah. So the one study, yeah, I will be finished. I will do a couple more questions, and then I will be finishing the live stream, because I think it's time for me to go and have some food and go for a walk, ironically. But there was one study called the Retune study, and this was where they took people of a BMI, I think it was 18.5 to 24.9. So they were classed as a normal BMI. And they found that even when they reduced their weight by about 10%, a lot of them had a reduction in diabetes in terms of a diagnosis. So direct, twin cycle, and Retune show that this is probable. And I have had 1 or 2 patients where we've actually done it. Not many people want to do it, but I have had experience where we've had 1 to 2 patients actually put their diabetes into remission. And with these GLP-1 pens as well, we're getting more and more clinic letters saying that this patient is in remission, so we need to stop all the other treatments. And that is just showing you that the GLP-1 pens, yes, they increase the insulin that's released, but mainly they work on energy balance and reduce the amount you eat, reduce the amount of storage. Please don't block the video. No, so all these lives that I'm doing now, they will all be put up onto the channel. So I'm trying to build up a bit more. I just obviously, the other lives that I was doing weren't the best. Answered every question. Amazing. Well done. Thank you very much. But fasting and calories deficit makes an individual so tired and exhausted. It does. It does. So that was only in that study. And just to bear in mind, in that study, they didn't really have any structured exercise programs. So the best way with any plan is to find something that you can adhere to for a long time. So let us just use, obviously, I don't agree with the calorie model. And the reason being for losing weight is that there are so many complexities to it and so many variables that change. But for the context of this and the purpose of this, I'm going to use calories. So if you are pre-diabetic or type 2 diabetic, you should really measure how much food you are eating, because we are inherently biased. And let's say you are consuming 3,000 calories each day, which probably wouldn't be out of the ordinary for a lot of people with type 2 or pre-diabetes. Now, the first thing that I would do from that is look at your baseline level of activity. So are you doing any muscle building activity? Are you doing any aerobic activity? If you're not, keep the diet maybe the same in terms of energy, but increase the amount of weightlifting. I'm going to put weightlifting, not weight. And increase the amount of cardio that you are doing. Maybe try weightlifting twice a week and try and do cardio 1 to 2 times a week. Even if it is, like I said, a 10-minute walk after a meal, which is what I'm going to do later. Keep the energy the same, because you will obviously have a reduction in energy being stored. And if you reduce that at the same time as doing that, you may feel more tired. But the whole outcome of this is that you will reduce fat and you will increase muscle, which is all beneficial for diabetes. What you can do with this is maybe still have the same energy, but make sure that your food is coming from whole foods. So 80% of them from whole foods. You are having more of your energy from protein. You are having more of your foods from fiber, and you are reducing the amount from ultra processed, like I said, and you are reducing the amount from saturated fatty acids, or even worse, trans fats. If you do that, then you are going to get probably a similar result. And then over time, you will reduce the amount of energy that you can. You will increase the amount of muscle. You will reduce the amount of fat. And you will basically become very much metabolically healthy. So you don't have to go for the classic, I'm going to strip back to 800 calories a day. They've done this in this study for the purpose of showing in a very short time that you can reduce your blood sugar levels and increase the chance of remission when diabetes is present. Lee, what is your next live about and when? Okay, so this is what I'm going to end on. I will do another poll on the community tab, and I am thinking about doing it on B12. The reason being is B12 is involved in a lot of nerve function. It's also involved in many reactions in the body. So if you have low levels of B12, then you are not functioning at the correct level. And a lot of people in this day and age are taking a lot of medication, like I said, metformin. You've got proton pump inhibitors. They are having poor amounts of fiber in their diet. They are having more plant-based diets, which are not supplying enough B12. And I've been asked to look into it a bit more with the patients at the surgery. So I'm going to look into B12 a bit more, because since I last looked at it, there's been a few advancements with treatment, and it is a lot more complex than what meets the eye. You have to look into whether you've got stomach damage and what you treat, what you test, what are the symptoms that you should look out for. So I have a million questions about B12. Okay, so that is what I will probably do. So that will be, so if you've got any questions about B12, the live stream will be at, if I write it a bit bigger, so this is probably going to be my normal live streaming time, 7 or 7:15 p.m. And that will probably be on Monday. And this is obviously UK time. So I will go through B12, I will go through diagnosis, I will go through testing, and I will go through treatment. Again, I will have to say it again for one more time. This is not medical advice. It is just for informational purposes only. And I feel like it's a lot better that people are aware of these things and can go and speak to health professionals. Also, bear in mind that if you discuss some of these topics with a health professional, you may get a bit of pushback, because some of them will not be aware of some of these mechanisms. They will not be aware of how to treat certain conditions. But it is always worth bringing up, because I always think someone to be informed is the best outcome. But saying that, thank you for everyone who is watching you from the west coast of the USA. Thank you very much. So you are, give or take, 8 hours behind. So it will be about 11:15 in the morning, US time on, well, West Coast time on Monday. So that is what I will be doing. Thanks for anyone who's asked, so this is medical advice. It's not, but I would like you just to be informed, because I feel like that is the best way to go with it. Thanks for anyone who's watched and asked any questions, and I will see you in the next live next week. So see you soon and have a good weekend.